Welcome to yet another episode of Pulmonology Read Aloud. My name is Dr. Anshu Maneja Arora, and today we are going to be discussing the joint ERS EACTS ESTS clinical practice guidelines on management of adult pneumothorax. And this is for adult spontaneous pneumothorax, both primary spontaneous and secondary spontaneous. So, this document was published in the end of 2024 in European Respiratory Journal, and it is a very important document because there have been a lot of newer approaches in managing pneumothorax, and this document clearly defines the available evidence for these approaches and whether we should be using them for pneumothorax management. Let me start with the key results that are shown in this document. It's a multidisciplinary task force developed guideline statement which has addressed 12 key clinical questions on management of pneumothorax, and it uses the PICO guideline methodology. Firstly, this guideline mentions that it's optimal for us to perform conservative care of those patients with pneumothorax who have minimal symptoms. So, if it's a primary spontaneous pneumothorax, stable patient, minimal symptoms, it's better to do a conservative management. Next, there is a very strong recommendation for needle aspiration instead of a chest drain for initial management of primary spontaneous pneumothorax. So, again, stable, not very severe patient, you should preferably do a needle aspiration first and not start away with a chest drain. Thirdly, there's a conditional recommendation that you should try to manage the patient in an ambulatory way. You need not admit every patient of pneumothorax if it's a primary spontaneous pneumothorax. What they also mention is that conditionally, if you think that this patient will have a recurrence because of, say, his occupation or because of his build or any other issue, then you can offer him an early surgical intervention because you know that there could be a recurrence. Also, they conditionally recommend that only in patients with secondary spontaneous pneumothorax, which occurs because of an underlying lung disease, an autologous blood patch could be tried in patients with persistent air leak. This does not hold true for primary spontaneous pneumothorax. And for other ways and interventions like bronchial valves, pleurodesis, suctioning, surgical resection, surgical pleurodesis, they could not make enough recommendations because they did not have evidence to support all of these. So the guideline is divided into 4 sections. The 9 PICO questions are divided into the first 4 mentioning about the initial management of spontaneous pneumothorax, question number 5 to 7 on management of persistent air leak, and 8 and 9 on optimal recurrence prevention techniques. This is basically following the initial 2015 ERS Task Force statement on diagnosis and treatment of the primary spontaneous pneumothorax. What they've done is they have added recent evidence on conservative care, on needle aspiration, ambulatory management, and formed this new recommendation. So this is a very, very important flowchart that kind of summarizes a lot of this recommendation. It divides primary spontaneous pneumothorax and secondary spontaneous pneumothorax. For patients who don't have a suspected lung disease, it would be PSP, and for patients who have a suspected lung disease, would be secondary spontaneous. Now, if it's a primary spontaneous, you would prefer ambulatory management, as they've mentioned. You would also prefer needle aspiration in symptomatic patients who are otherwise stable, and you would suggest conservative care in them. If the patient is okay with ambulatory management, you will discharge him with an outpatient review. If on needle aspiration he resolves, again you can discharge. But if he doesn't, it doesn't resolve or it recurs during your observation period, you may need to insert a chest drain and admit. That's the usual practice. They did not basically mention much about the evidence, and this is where evidence is not enough. So they use the practice points from the task force members. And then they suggest that you can consider VATS in case you think that it needs to be prevented for recurrence. Now, if you're doing conservative management, you have to observe your patient for a few hours, and only when they're stable, you send them home. Otherwise, you would do a chest drain. In case it's a secondary spontaneous pneumothorax, things change a little. You would want to insert a chest drain definitely and admit. Check if there is any air leak. If there's no, then you can discharge. Otherwise, you have to look out for ambulatory management. This is the summary of the evidence that they have used in this guideline paper. They have reviewed only one major study which talked about observational care. And in this, 9% patients had a recurrence of pneumothorax in a year, with 15% patients requiring further pleural procedure. As compared to this, if you look at the studies looking at needle aspiration, there were around 6 main studies. And here, 2.5 days average hospital stay with a 25% chance of recurrence, a 22% chance of another pleural procedure. For patients who were not admitted and in ambulatory care, there was one major study which again had 24% recurrence and 21% procedure requirement, which is why they mentioned they would prefer ambulatory care. But if you look at it, there's just this one study which has been referred to. Then chest drain, around 6 studies where they had a 4.8 average day of stay, but with a similar kind of pneumothorax recurrence of 21% and 25% pleural procedure requirement. But with surgery, definitely the stay was longer, but the recurrence and requirement of further pleural procedure was as low as 3 to 6%. And they did look at significant number of studies for that. But one major study that they have talked about. So if you look at it, when they say needle versus chest drain, they see a similar kind of recurrence. So they mention that you should prefer to do needle first, and surgery, though much better, but it would be preferred for secondary spontaneous rather than the first case of primary spontaneous. So the PICO 1 question is, should conservative management be used? The answer is yes. They say that if you're looking at primary spontaneous in selected cases which are minimally symptomatic, clinically radiologically stable, you could just do a conservative management and observe them. But do you do that in a secondary spontaneous? You do not. Now this comes out of non-inferiority outcome studies in pneumothorax resolution. They say that the length of stay is less, there's better quality of life, there's no increase in adverse effects in patients who were given a conservative management, and the pneumothorax recurrence is not very high. But then there are other non-randomized studies where you might find a recurrence. There are 6 non-randomized studies which these paper has looked into. And they say that when you compare large pneumothoraces and then compare them to Seldinger's drain or conservative management, the primary outcome of resolution was seen in around 98% patients in the conservative management and 94% in the conservative and 98% in the chest tube. So they say it's not much of a difference. So you could also observe them. However, the length of stay will be shorter if you do conservative management. But more or less, they haven't found much difference between the arms of the study. And so they have recommended this. But you have to ensure that your patient is stable, observed in the emergency for at least 4 hours, able to walk around the emergency department, and capable of doing routine activities, and call them back for a follow up. If they're not willing to come back for a follow up, if they cannot walk in the emergency, it's better not to do conservative management. The second question is whether you should do a needle aspiration versus a chest drain. The answer is that if it's an initial treatment of primary spontaneous, you can do needle aspiration. It's a very strong recommendation, but this is not the same for a secondary spontaneous pneumothorax. So, although it's a strong recommendation, the evidence is of low certainty because they have looked at 6 RCTs and 2 observational studies. And it's based mainly on the fact that if you do a needle aspiration, the length of stay is shorter, the complications are less. So they think that if you look at the patient's point of view and clinical outcome point of view, even a needle aspiration can be well. But remember that all of these have a risk of bias from the participants, because you may be biased to not do a chest drain, the personal bias, the participant bias, because you're comparing a non-invasive procedure versus an invasive procedure. So, although the studies were of reasonable size, there still is lack of very good quality data. And so they do give a strong recommendation based on outcomes, but they say that the certainty of evidence is not so good. In fact, they've seen studies where a chest tube between 12 and 28 French is compared to a needle aspiration, which is a 16 gauge needle or an 8 French catheter. And they also looked at studies where patients might have to undergo a second aspiration. They've also looked at meta-analysis, which compare needle aspiration to chest tube drain. And again, shorter days of hospitalization was the main outcome and lesser risk of complication. But if it is a stable patient, at least the guideline says that you can go ahead and watch out with the first needle aspiration. For PICO 3, the question is, should you use ambulatory management compared to the needle aspiration, chest drain, or admission? And they suggest that you can do ambulatory management where you have that expertise and the pathway where the patient can come back for follow up. He gets an appointment with you, he gets to see you. But it's again a conditional recommendation. The evidence is not that good. And they suggest that if you have to use an ambulatory device like a Heimlich valve, or you're attaching a drainage device and sending the patient home, it's better that you ensure that your chest drain is of an adequate size. So they recommend against using a small bore ambulatory device or a 8 French chest drain for such patients with secondary spontaneous, because if you're sending them home, you might as well send them with a better size of chest drain. So again, a conditional recommendation because the certainty of evidence is low, and the data suggests that there was a decrease in hospitalization length. There was also a decrease in readmissions, if in case you manage it well, even on an ambulatory basis. But when we are looking at secondary spontaneous pneumothorax, they are underpowered studies. There's still a high risk. And in case of ambulatory device, a Heimlich one-way valve will remove the need for admission. It'll allow outpatient treatment, and it's cost effective also compared to a admission. So that's why they feel that ambulatory pathway requires consideration, but you should have that expertise to make an informed decision. And why this 8 French thing has come, because they've looked at studies where there could be a harm for patients with secondary spontaneous pneumothorax being managed with an 8 French ambulatory device. There may be a role for a flutter valve system with a device at least more than 12 French. So that's the reason why they've mentioned this specifically here. There are a lot of studies which have looked at 8 French versus 12 French. And although the length of stay might not be different if you're keeping them indoors, but if it's an ambulatory device, they mentioned that the 8 French one could fail. So they won't want us to risk it. Pico 4 is whether early surgical management or medical management be used in an acute initial presentation, and they conditionally recommend that you should use early surgical intervention in those where you want to prioritize recurrence prevention. So, early surgical intervention means first presentation for pneumo and you send them for a surgery after you stabilize them with a chest drain, right? But this any recommendation for or against in an early secondary spontaneous pneumothorax does not have that much evidence. So it's a conditional recommendation, and the data suggests that less recurrence occurs if you do surgical intervention. But there are less number of patients analyzed. They haven't analyzed enough outcomes, so the strength is lowered by lack of outcomes in the studies and application to all patients. Certainty of evidence is also downgraded because a lot of these studies have been unblinded studies. So they've included two RCTs, including 222 patients with primary spontaneous, and all the studies were non-blinded to participants and clinician. So you don't know whether there's a risk of a bias, and also patient related outcomes were not really measured in these studies. So that is why implementation of early surgery will require a very good collaboration between the emergency room, between the respiratory doctor, between the thoracic surgeon, and if you look at low economy countries, it may not be feasible. So they did not say a clear cut indication, but they said that if you do it, there will be lower recurrence rates compared to a medical management. So in that way, during the first episode, if there is a possibility and there's a risk of recurrence, then you must go ahead and do it, because it will reduce the overall recurrence. It will reduce the risk of persistent air leak, and secondary spontaneous pneumothorax. First episode, they say that should be more RCTs to look at other factors to give a clear cut recommendation. Now, the next Pico question was regarding autologous blood patch. So, the question is if autologous blood patch can be used for managing persistent air leak in a spontaneous pneumothorax compared to just putting in the chest drain alone. Now, this panel could not recommend for or against the use of autologous blood patch in primary spontaneous pneumothorax. So, patients of primary spontaneous pneumothorax, if they are not fit for surgery and they have a persistent air leak, should you go ahead and do an autologous blood patch? They could not comment because the evidence wasn't as robust. But they did mention that if you're looking at secondary spontaneous pneumothorax in adults with persistent air leak who are not fit for surgery, it is an option. Now, this is again a very conditional recommendation because the quality of evidence wasn't very strong. And this conditional recommendation is for secondary spontaneous pneumothorax in favor of that rather than a primary spontaneous pneumothorax. So, wherever autologous blood patch studies have been done, they've looked at RCTs and they've found that when you do use this technique, there is a reduction in the duration of the air leak as well as the length of hospital stay compared to a standard care, but there's no extra difference in complications, so it makes it a viable option. Now, when there is secondary spontaneous pneumothorax, the evidence is also low, the studies are also less. However, conditionally they could recommend this because there is so much heterogeneity in the interventional approaches. They could not make a very strong recommendation because when you look at those studies, we look at intrapleural autologous blood patch delivered either via a chest tube or autologous blood patch delivered via a bronchoscope. So there's a lot of heterogeneity in what is the way it is being used. But they've also commented that dosages is also very, very heterogeneous. Overall, they've mentioned that if at all it has to be done, the dose is usually 1 to 2 ml per kg of the blood patch based on this available literature so far. So, no strong evidence for primary spontaneous, a conditional recommendation based on evidence for secondary spontaneous pneumothorax. Pico 6 is about bronchial valves. So, another interventional approach. Should you use bronchial valves for managing persistent air leak in a spontaneous pneumothorax as compared to a chest drain alone? Here also, there is lack of clear cut evidence. So, again, they clearly mentioned that we cannot make any recommendation either for or against for those who are not fit for surgery and need this intervention. But the same is for even secondary spontaneous. So, for both primary and secondary spontaneous pneumothorax, here they could not recommend for or against bronchial valve. So, there was no recommendation because there was insufficient study data. And why? Because a lot of these studies were unblinded studies. They were very, very small populations, and the small number of studies and the grade assessment, all of that has shown that there's a serious risk of bias, there's inconsistency, and the complication data is also very varied. So they said that there could be potential side effects, adverse events, and practical considerations can really vary. There's also not much on the cost that it would be to the patient and whether it's cost effective enough. So endobronchial valves for or against, unlikely that whatever studies we have will highlight what to do, but future research is definitely warranted. Coming to the next question, which is about suction. So, should suction be used for managing persistent air leak? Again, if you talk about primary spontaneous pneumothorax, recommendations are not very clear to advise for or against, and same is for secondary spontaneous pneumothorax because they did not find enough RCTs which were eligible for inclusion. They found a single center RCT of 29 patients, which compared a standard chest tube drainage with suction, either at minus 10 or minus 20 centimeters water. And this RCT did include iatrogenic and spontaneous pneumothoraces, where spontaneous were a little more and iatrogenic. So there were around 17 spontaneous and 12 iatrogenic. In this trial, the chest tubes were removed at 48 hours in almost 57% patients if they had a minus 20 centimeter water suction, and in a larger percentage, which was 73% patients with a minus 10 centimeter water suction arm. But in the only if you're looking at the underwater seal, 45%. So basically, they said that out of all the patient population, 17% had a persistent air leak. So you don't have very good numbers and you have very imprecise if estimation. You also could not really say whether there was a risk of more complications. So, what was the risk of pneumothorax resolution with suction? That also has a lot of bias in interpretation. So the justification came that no recommendation can be given. The quality of data that we have is poor. There's a lot of heterogeneity. The same study is looking at iatrogenic and spontaneous and underpowered study. 29 patients out of a target of 120 is an underpowered, unblinded study. So because of all of these bias, it could not be used. There was an RCT which compared suction and standard chest tube drain in spontaneous pneumothorax with persistent air leak, which looked at patient centered outcomes. And here they could not estimate what is the benefit of the suction itself. They were looking at patient outcomes, patient comfort. So, therefore, recommendations are not clear on this. Pico 8 is whether you should use VATS alone for recurrence prevention compared with VATS plus surgical pleurodesis. So, here again, they said that pulmonary intervention, when we are talking about, is any intervention which is done on the lung. Either you can undertake it alone or you can do it with an attempt to do a pleurodesis during the surgical intervention to prevent the recurrence. Now, here they could not make a very clear cut recommendation again because, again, the evidence is mostly inconclusive and scarce. They did not see much difference between intervention and control arm for recurrence and length of stay in the hospital. And this is what we were looking at. We were either looking at recurrence or length of stay. And again, these studies are non-blinded to participants. They don't consider patient-related outcome. They don't consider costs, and they also don't have, or it is not possible to have crossover arms. So they said future research is definitely needed. If you look at surgically managing primary spontaneous, it traditionally is on bulectomy plus pleurodesis. And in the studies that they did consider, out of around more than 1,000 patients, only 42 patients had received talc pleurodesis as opposed to the surgical intervention. So it was a very biased kind of a study arm. You can't really comment on the efficacy of chemical pleurodesis here over bulectomy alone. So, two RCTs, three large retrospective studies, they were all considered here. But again, whether it's a thoracoscopic procedure only or a thoracoscopic procedure with pleurodesis or proper VATs with talc. So all of this has added to a lot of heterogeneity, and there is a difference in the recurrence rate and the length of hospital stay and so on. So that is why they could not make a definite recommendation. Now, after these initial PICO questions, there were few other things that were mentioned in the paper. The first is whether surgical pleurectomy. So these are like more like patients where a surgical intervention is being done. So should a surgical pleurectomy be used for recurrence prevention in spontaneous pneumothorax compared to a chemical pleurodesis delivered surgically or medically? So surgical pleurectomy means apical parietal surgical pleurectomy and chemical pleurodesis. They are actually both available acceptable treatments, but the recurrence rates are comparable. So here they did not make any recommendation for or against it, either in primary or secondary spontaneous pneumothorax. They looked at an RCT, which was a single center RCT of 160 patients, and they did not see. So here there were no identifiable blebs, or there were multiple blebs. So they demarcated the patient population into these groups, and the patients underwent apical pleurectomy or pleural abrasion with minocycline along with stapled bulectomy. This was one RCT. Another RCT that was looked at was one which compared thoracoscopic resection of the bleb or electrocoagulation versus electrocoagulation plus pleurodesis. And here also there was a very small patient population of 49 patients in the study arm. So meta-analysis also that have been done have been heterogeneous and haven't found much difference in recurrence rates. So the panel does not make any strict recommendation for this, and they haven't found any differences in recurrence, complication, or mortality. However, if you look at surgical pleurectomy, the length of hospital stay was shorter, and so the justification is that there are so many limitations and uncertainties in the evidence that you cannot make a recommendation for and against. Coming to narrative question, the first narrative question was about the optimal method of predicting clinical course and recurrence. So here they are looking at a question to all the task force members about what do they think will be the optimal method to predict whether this patient will have recurrence. And they looked at all the studies to ascertain that. Now, they could not make any particular recommendation about the optimal method, and whether you should use digital air leak measurements, or you could use pneumothorax size or symptom duration to say that this patient will perform better and this patient might have a recurrence. So they said none of these can be used as a marker. Secondly, they looked at radiology and whether a radiological identification of a large bulla is predictive of long term recurrence risk. So they said that yes, there is some association with how large your bulla is and long term recurrence risk, but you need more evidence. And so you cannot say that we need to perform the CT scan at a particular interval to look for whether this patient will have recurrence. So, findings from various studies have shown that if you're looking at blebs or bulla, then it's inconsistent. Most studies are retrospective, they have a big bias, and only large blebs have association of high recurrence. Predictors, no conclusions you can draw. The second narrative question has been about factors which influence determination of fitness for surgery and timing a surgical intervention for persistent air leak. So they say that whenever you are thinking that this patient with secondary spontaneous pneumothorax has a persistent air leak, needs to be sent for thoracic surgery, you should look at the patient's age, the comorbidities, the type of the lung disease, his performance status, and his ASA score, degree of emphysema on the CT. And this is again conditional. The justification is that whatever evidence they saw for these factors, that is very low. So even though this is recommended, but there is not very good evidence for each of these factors. There's a large selection bias. There's a lot of observational data. And however, there are no RCTs to say that age more than 50 or less than 50 or ASA score this or not. So they don't have too much of randomized data. And these are all practical considerations that you can do. And if we try to extend the criteria of a lung volume reduction surgery, for instance, or using lung function exclusion and all, you cannot apply them to a patient who has a indwelling chest drain. So you can't even use the FEV1 criteria or FVC criteria to determine fitness of surgery, right? So you cannot do an estimation of spirometric values when you are having a pneumothorax. So you just can't use that also. So they said that, okay, we can extrapolate certain risk factors from lung surgeries, but in general, you don't have very strong evidence for any of these in particular. And they did not find any studies that examined timing of surgery in secondary spontaneous. So they said the timing is determined by potential risks of leaving the drain. So this patient might have an infection if you leave it for long, if it's an elderly mobile patient, what are the risks of general anesthesia for that patient. So all of that will determine your risk. Definitely a large air leak, non-expanding lung, that will need an early intervention. You don't want an empyema, but if the lung is expanded, you may want a closed chemical pleurodesis via a chest drain because it may be a high risk procedure. So there's a lot of need for prospectively collating data, randomizing studies, and then looking at surgical versus non-surgical interventions. The next question is about patient-centered implications of a pneumothorax. So, uh, pneumothorax is a teachable moment, because you can tell the patient that this has happened because of some risk factor. So here they say that when you have a patient who's a smoker and has a pneumothorax, please use it as a moment to emphasize that he needs to stop smoking. So patients who smoke have likelihood of recurrence. Patients with untreated spontaneous pneumothorax should not fly, and they should wait at least 7 days after the radiological resolution before flying due to a risk of early recurrence. Coming to smoking, they have given some text regarding smoking because there's a very, very strong link between smoking and pneumothorax, a clear dose response relationship. So they suggest that there's a very strong correlation between a person stopping smoking and reduced recurrence. In fact, if he's smoking at the time of VATS, that will increase recurrence risk. This finding, though not universal, it's a very good way of inducing lifestyle changes for patients. Coming to flying, uh, earlier the guidance used to say that a patient with spontaneous pneumothorax, you do a chest x-ray, you check he's responded, he waits for 7 days and he takes a flight. Now, if you look at the risk of recurrence within a week of discharge of a pneumothorax, it's not very high. So, but evidence says that if you've recently treated small pneumothoraces, they will not cause any significant issue. But this is a pragmatic advice. There are case reports of uncomplicated air travel in chronic pneumothorax, but there are also cases where it could worsen. So, one thing that can be done is something which is called a hypoxia challenge test, where they expose the patient to hypoxic, hypobaric environment in a decompression chamber. Again, patients who have cystic lung diseases like LAM, they may also have a higher risk of pneumothorax with air travel. So, they also should have a lower threshold to have a chest x ray before, during, or after a flight. That's also something which is important. Coming to physical activity, will a patient have physical activity related pneumothorax? So, there are case reports where a patient who had pneumothorax and he was playing a musical instrument, or was shouting or blowing up balloons. Again, there could be a physical effect of Valsalva, which could cause this, but not strong correlation. So the guideline supports BTS recommendations that certain occupations like diving after a pneumothorax have to be permanently discouraged, and patient-centered implications um, are are not looked at into so much, but we must look at patient priorities and look at those groups to give them more guidance. So, to conclude, managing spontaneous pneumothorax is contentious. We have lot of evidence since the last ERS task force, but effective intervention may not always be the one which has evidence backing it. So, this guideline adds to it. It does give us the availability of needle aspiration and also of ambulatory care. This is actually one of the first guidelines to look at specific PICO questions regarding persistent air leak and autologous blood patches, and also addresses surgical issues. So, with that, a further research, further aspect to uh, research is important, and they do acknowledge newer RCTs coming, and hopefully, we'll have more guidelines in the future. So, with that, I end this talk, and I will be coming with more and more guidelines and latest in pulmonology. If you haven't subscribed to my channel till now, I request you to please go ahead, subscribe, and share this channel. And I look forward to your comments about newer topics that you would like to listen. Till then, happy reading and bye.